everyone, and welcome to the Network for Healthy Populations virtual seminar series. And I'm pleased to open up our first seminar of the year of 2025. And Happy New Year to all. And I hope people are staying warm on this very, very cold day. So my name is Lorraine Lipscomb. I'm the director of the Nova Nordis Network for Healthy Populations at the University of Toronto. Today's session is the joint Network for Healthy Populations Banting and Best Diabetes Center, BBDC, joint clinical rounds. Sorry, joint research and progress rounds. I'm going to start with a land acknowledgement. So I would like to start by acknowledging this land on which the University of Toronto Mississauga operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. We have the privilege to work, study, and research on this beautiful campus bordered by the Missinaihi Trusting Creek, called the Credit Valley by the French and British colonists who at the river's mouth traded goods on credit with Indigenous peoples who had traveled and stewarded these waters from time immemorial. I'm also currently coming to you from Toronto, which is covered by Treaty 13. And I'm personally grateful for this land that has provided me with a place to live, work, and raise my family. And I recognize that this privilege comes from the stewardship and care of the Indigenous peoples who've lived here for millennia. So welcome everyone. Thank you for attending today's session. We have, as is usual for our clinical and population research and progress rounds, we are excited to give an opportunity for students and trainees to present their research and progress. And today we have two students who will each present for 20 minutes, followed by a question and answer period. The first one is Ibrahim Ghanem, and the second one is Ijeoma Etanyi. Before I introduce the speakers to you, I'd like to quickly review some housekeeping items. We appreciate our audience muting themselves during today's session. And there'll be an opportunity for questions at the end of at the end of each talk, and we'll be inviting questions both through the chat box or by using the raise hand function. If you have any questions during the event that you'd like the speakers to address at the end of the session, please enter them into the chat box. And lastly, please note that today's session is being recorded, and we will make the recording available on the network's website. I just also want to put a plug in here before I introduce you to our first speaker for our Network for Healthy Population Summer Research and Training Program. Here you'll see on your screen that there is a QR code to apply. If you are enrolled at University of Toronto, you are an undergrad, medical or non-thesis Masters of Public Health graduate student, and you're available to work full-time during the summer, this opportunity is for you. The deadline is fast approaching. It's on January 24th, 2025. So if you're interested in enrolling, please do so in the next couple of days. So now I'd like to introduce you to our first speaker, Ibrahim Ghanem. He is a PhD candidate under the supervisor of Dr. Kathy Wilson at the University of Toronto, Mississauga, Department of Geography, Geomatics, and Environment. Ibrahim's faculty advisor today, who I'd like to introduce, is Dr. Ghazal Fazli. The faculty advisor has been selected by our speaker to lead the question and answer period and to provide some important feedback to the trainee as they're developing their research project. Ibrahim holds a master's degree in spatial analysis from Toronto Metropolitan University, and his research interests include examining access of marginalized communities to social and health promoting resources, immigrants' health, and contextual determinants of health. And his research is about bridging the gap between quantitative geography and solutions for creating healthier and inclusive neighborhoods. And at this seminar, he will share his research on leveraging multiple neighborhood level and individual level data sets to investigate the impact of neighborhood walkability on health outcomes of the Arab population in Canada. So without further ado, please join me in welcoming Ibrahim Ghanem to speak today. Go ahead, Ibrahim. Ibrahim, sorry.
Thanks, Lorraine. Can you see my screen?
Yes, we can.
Okay, thank you. Hi, everyone. I will be presenting ongoing research with the title of Analysis of the Impact of Neighborhood Walkability on the Presence of Chronic Diseases among Arab populations in Canada. I want to state that I have no actual or potential conflicts of interest in relation to the program of the Novo Nordisk Network for Healthy Populations. Regarding the context, this research is part of my dissertation, which examines how neighborhood physical and social environments shape health outcomes and access to health promoting resources among Arab populations. It is structured into 3 chapters. The first examines how neighborhood walkability influence health outcomes. The second explores how walkability impacts access to healthy food environments. And the last chapter compares subjective walkability with objective measures for this population. For today's presentation, I will be focusing on chapter 1. I will begin by providing a background on the proposed topic and narrowing in on the specific focus of my research. Then I will introduce the questions and the conceptual framework guiding the analysis. Next, I will explain the proposed methods, followed by discussing the potential contributions and limitations. And finally, I will conclude with the next steps. Starting with neighborhoods, which encompass the physical environment, social environment, and health promoting resources referred to as service environment. These environments can influence a range of health outcomes, including risk factors, chronic diseases, and mortality. The 3 environments are not independent, but interact with each other to influence health. These interactions are further shaped by individual characteristics. Hence, examining these complexities requires investigating both these environments and their differential impacts on individuals with different characteristics. Regarding walkability, it is one type of a neighborhood environment, and it refers to how conducive a neighborhood is for walking as a mode of transportation or recreation. Walkability elements can be broadly categorized into a mesoscale, which considers neighborhood level features, and a microscale, which assesses street level factors that directly impact pedestrian behavior. Examples of walkability elements include residential density, street connectivity, and sidewalk infrastructures. Walkable neighborhoods can promote physical activities among residents, which in turn can reduce the risk of chronic diseases. In this context, existing literature found that walkability is a contributing factor for better health outcomes for non-racialized, racialized, and immigrant populations. Nevertheless, there is a gap in research investigating the impact of walkability on specific racialized groups in Canada. One of these groups is the Arab population, which is an underrepresented population in the health geography literature. Arabs include individuals with ethnic or cultural origins in the Middle East or North Africa. This population is projected to have one of the highest growth rates in Canada, reaching up to 5% for the year 2041. Despite this projected growth, the understanding of the health status of this population and the conditions of the neighborhoods that they live in remains limited. To tackle this gap, this research focuses on understanding how neighborhood walkability influences the health outcomes of different groups within the Arab population in Canada. Specifically, it examines Canadian-born individuals, recent and long-term immigrants, aged 20 to 64 years old, living in the 10 largest census metropolitan areas, CMAs. These CMAs are home to 84% of Canada's Arab population. The health outcomes of interest include diabetes, which affects 12.5% of the Arab population, and heart disease, which impacts 2.6 million Canadians overall. Also, the research explores the related medical risk factors, including asthma, angina, and high blood pressure. The research aims to answer 2 questions. First, Does neighborhood walkability differentially impact the health outcomes of Arab populations compared to other visible minority groups and non-visible minority groups? Second, to what extent do neighborhood social environment factors moderate the relationship between walkability and health outcomes across different population groups, including Arabs, other visible minority groups, and non-visible minority populations? The conceptual framework of this research acknowledges that the relationship between walkability and health outcomes is not always direct, as potential mediators may exist to influence the strength of this relationship. One of the mediators can be the social environment. For racialized populations, ethnic concentration and social cohesion reflecting sense of belonging can promote better health outcomes, especially for females, as it entails better interaction with their surroundings. However, material deprivation and marginalization within high ethnic concentration areas can restrict access to health-promoting resources. For example, those facing discrimination and marginalization may not fully benefit from accessing health-promoting resources in their neighborhoods. Another mediator can be the acculturation, which is the process by which individuals or groups adapt to the dominant culture while maintaining elements of their original culture, with varying levels of integration depending on individual and community characteristics. In this context, residents with higher acculturation may be more likely to utilize walkable infrastructure effectively to support their mobility and lifestyle preferences. The last mediator in this framework is the social mobility, which refers to the ability of individuals or groups to move between social and economic hierarchies over time. It encompasses changes in social status, typically measured through factors such as income, education, and employment. In this context, individuals in neighborhoods with higher upward social mobility are more likely to access better healthcare, adopt healthier lifestyles, and benefit from resources that walkable environments can offer, such as proximity to amenities and active transportation. To proceed with the methods, the research will utilize 4 datasets. The first is the active living environment indicators, which will serve as measure of walkability. This include a combined score for street intersection, dwelling density, transit stops, and point of interests that represents access to amenities such as schools, shops, and parks. Second, the health and lifestyle data will be sourced from the Canadian Community Health Survey, CCHS. Third, data on perception of on shared Canadian values will be collected from the General Social Survey, GSS. And lastly, the demographic data on racialized populations will be extracted from the 2021 Canadian Census and Statistics Canada custom tabulations. Regarding the neighborhood operationalization as presented in this diagram, following the 15 minutes walk theory, the neighborhood will be operationalized using 1.5 kilometers GIS-based buffer from the postal code of CCHS participants using the pedestrian network. Thereafter, participants will be linked to neighborhood level characteristics that will be associated with the centroids or the centers of the census tracts falling within that buffer. Moving to the social environment or the data preparation in general, while standardization methods will be used to identify ethnic concentrations, special autocorrelation will be used to identify ethnic enclaves that represents clusters of ethnic concentration. Regarding social mobility, following the Urban Institute Upward Mobility Framework, the study will compute the numbers and percentages of a neighborhood racialized populations meeting the 5 criteria of speaking an official language, holding a Canadian citizenship, holding a high education degree, being employed, earning a high income. In this context, high percentages will indicate high levels of social mobility and vice versa. Regarding social acculturation, this measurement will be based on assigning numeric values to the response options for the 6 shared values identified by the GSS that include human rights, gender equality, official languages, ethnic and cultural diversity, respect for the law, and respect for the indigenous culture. Similarly, high scores will indicate high levels of social acculturation and vice versa. Regarding answering the first question, which is, does neighborhood walkability differentially impact the health outcomes of our population? Multi-level logistic regression will be employed to examine the potential association between neighborhood walkability score and a set of dependent variables representing individual health outcomes in the form of binary values. Separate models will be developed to account for variation across population and subpopulation groups, such as immigrants versus non-immigrants and recent versus long-term immigrants, with a cutoff 10 years period. The models will control for potential individual confounding factors, such as age, gender, BMI, lifestyle, physical activity level, and household income. Regarding answering question 2, which is about to what extent do neighborhood social environment factors moderate the relationship between walkability and health outcomes? Path analysis will be utilized to explore the mediating roles of the social environment factors that were described earlier. Separate models will be developed to analyze this process among Arab and other population. Moving to the last stage here, which is about the potential contributions and limitations. The research contributions are circulated around first addressing gaps in understanding how neighborhood walkability influences health outcomes among an underrepresented population in literature. Second, it will examine the healthy immigrant effect by investigating whether recent Arab immigrants experience better health outcomes compared to other groups. And third, it investigates the rules of different social environments in mediating the relationship between walkability and health outcomes, which is rarely covered in literature. With regard to limitations, first, the use of cross-sectional data from the CCHS limits the ability to establish a causal relationship between neighborhood environments and health outcomes. Second, the GIS-based buffers may not accurately capture residents' actual activity spaces or daily mobility patterns, as individuals often interact with environments beyond the predefined buffer distance around their residential areas. Third, while the research centers on Arab population as a cohesive group, it acknowledges the diversity within this identity, which may further shape their interactions with their neighborhood environments and their health outcomes. Yet obtaining granular level for this identity may not be possible due to Statistics Canada restrictions on data. Lastly, the study controlled will be controlling for different variables to account for potential self-selection and lifestyle differences to ensure an accurate analysis of the relationship between walkability and health outcomes. However, the absence of a standardized framework to guide the selection of appropriate control variables remains a limitation in this study. Finally, regarding the next steps, during March 2025, I will aim to obtain access to the data at the Research Data Center. Afterwards, I will aim to develop measurements and carry out the analysis and the writing in a period of 3 months that ends by June 2025. Here are some of the selected references that are used to build that structure of the study. And lastly, I would like to thank my supervisor, Professor Kathy Wilson, and the committee members and the advisor for their ongoing support and feedback. I would like also to acknowledge the funding for this work that is supported by the Novo Nordisk Network. And thank you.
Thank you so much, Ibrahim. That was a really nicely presented proposal, and we're looking forward to seeing the results. Really well done. I'm going to pass it on to Dr. Fazli, who can get started with some questions.
Thank you very much, Ibrahim. I want to echo Dr. Lipscomb's comment. That was very nicely presented, and your research is truly novel, and it is going to address one of the gaps that we have not been able to hone in on in looking at the effects of the built environment, specifically neighborhood walkability on health outcomes of specific populations. I'd like to just add a few comments and then I have some questions as well for consideration for your research and next steps. I want to just quickly highlight that the work that you're doing, as I mentioned, the Walkability Index has been used and applied across several studies and measures across different contexts, geographies, and populations. And while we know that there's studies on how the walkability affects health outcomes, specifically immigrant populations have been shown by the work by Dr. Gillian Booth and all around how and why immigrant populations are more susceptible to these neighborhood effects, but we don't actually know how these neighborhood effects influence the health of Arab populations in particular. So, a couple of considerations for your research and some questions. You mentioned that you'll be using across three different data sources, and including 10 CMAs. Do you have an idea of which CMAs are you looking at in terms of more urban centers across Canada and roughly around sample sizes across the different data sources?
Yes, thanks, Ghazel. To start from the very end, no, I did not get access to the data set yet, so
Okay.
I'm not sure. Like I don't have like a clear understanding of the sample size. However, I'm planning to combine the most recent data sets for both CCHS and GSS to obtain a reliable sample.
Mhm.
And with regard to the CMEs, I'm planning to focus on the 10 largest CMEs by the population size. I don't have them on the top of my mind, but I selected these 10 CMEs because they host 84% of the Arab population compared to hosting 56% of the Canadian population overall. So there is a significant number of Arab population living in these urban areas. Um, um, so the boundaries, or if I will be focusing on a certain typology such as urban and not rural, this issue I will be deciding on once I get access to the data and see how the data is distributed across both type of typologies.
Wonderful. Thank you.
Thank
Yeah,
you.
because that's going to be an important piece for understanding which populations are represented across, or what is the proportion of the population being represented and across different CMAs. The other point I wanted to raise is that it's interesting that you're using the social environment as your effect modifiers, right? So one of the challenges that we face when we're talking about walkability is how does neighborhood walkability influence the health of racialized populations who face safety challenges or racial profiling? And I'm sure you have you have your theories around that, and particularly for the population that you're looking at. Um, do you have an idea of how you would account for in the current data sources or literature on how it can be used to explain how racism and safety, all of those things tie in when we're looking at health behaviors of specific populations who may be limited to engage in walking as a form of physical activity in their neighborhoods?
Thanks, Ghazel. Yeah, so I think this is a very important point to look into.
Mhm.
With regard to this chapter in my dissertation, I was mainly focusing on objectively measured walkability score.
Mm.
And these objectively measured walkability score usually primarily focuses on physical environment aspects such as street intersection, sidewalks, and etc. However, this issue about the perceived walkability, which would take into consideration items such as the ones that you mentioned, safety, racial profiling, perception of races.
Mm.
I'm working with my Professor Kathy and committee members on a third chapter for this dissertation, in which I'm capturing the perceived walkability for this population. In the literature, there has been always a gap between for any research that computed perceived walkability and compared it to objective walkability. There has been always a gap, and that was present by measuring the correlation between the two scores. So I'm expecting the same gap. However, for this chapter, we are planning to have some kind of qualitative insights, collecting qualitative insights from Arab residents in Toronto CMA
Right.
to just have a better understanding about what variables would impact their walkability, their perception of walkability, or their walking behavior in general. And afterwards, using these perceptions, we can go ahead and check their reliability or their relevancy to the general Arab population in Toronto CMA. So yeah, I agree with you. It is very important to take it into consideration. However, maybe the data variables for this chapter that we are talking about today might be limited. So
Right.
looking
Right.
forward to it in chapter 3. Thank you.
Yes, no, I'm glad that it is in your plans, and Dr. Wilson is definitely the leader in the field to support you with that. I'm mindful of time. Do I have time for one more comment and then questions, or?
So, because I'll absolutely, but I do want to make sure before you do that, if we could maybe Ibrahim can answer a question from the chat, and then we can come back to yours. We have about 3 minutes left. So
Okay.
I'll just read you what the chat question, you may see it as well. Great presentation. Can you describe some specific reasons why Arab populations might be affected by walkability differently than other immigrant populations? What's your hypothesis? I know Dr. Fazli alluded to maybe some aspects related to experience of racism and discrimination, but perhaps you could expand on whether there are other reasons or other hypotheses you might have.
Yeah, thank you. Thank you, Dr. Kelvin. So with regard to the first part of your question, are there reasons for why our population might be affected by walkability differently than other immigration populations? Yes and no. So there is limited literature about this population group. So we don't know how walkability impacts their health. My hypothesis here is that walkability can contribute to better health outcome for this group. However, this hypothesis can be wrong once I carry out the analysis. But the point is, like, for other research, for other existing research, like plenty of research found that walkability is very important for the health of the two groups, racialized and non-racialized. And for immigrants particularly, yes, walkability had a positive impact for recent immigrants. However, that positive impact did diminish for long-term immigrants. So, and the research that tackled this aspect focused on the very general population level. So in my research, I'm planning to also examine this potential healthy immigrant effect among Arab population. So I did not want to jump into hypothesis because more or less this research is still exploratory, but definitely taking into consideration what you have provided can be a starting point. Thank you.
Thank you, Ibrahim. Dr. Fazli, I'm afraid we probably should move on, but maybe if there's time at the end, you can connect with Ibrahim about your other questions. Is that okay?
Yeah, I will. Yes, thank you very much.
Okay, great. So once again, thank you so much, Ibrahim, for an excellent presentation. We're really thrilled to be supporting you in this work, and we're really looking forward to seeing the next phase of your research and some of the results. So thank you again. And we'll move on to our next speaker. So our next speaker is Ijeoma Atanyi. And she is a PhD candidate in epidemiology under the supervision of Dr. Laura Rosella at the Dalhousie School of Public Health at the University of Toronto. Ijeoma, are you able to turn your camera on? I just want to make sure you know that you're up. Wonderful. Good. We see you there. Okay. I just wanted to make sure you hadn't left your desk or something. Okay. So Ijeoma is specializing in data science and artificial intelligence, a really exciting area. She actually holds already a medical degree and a master's of public health degree. She also completed residency and fellowship in community health and preventative medicine. And prior to starting this program, her PhD program, she was actually a senior lecturer in epidemiology and community medicine at the University of Nigeria, where she led large-scale community-based research projects and played a pivotal role in establishing a national research infrastructure of clinical and implementation research. So we're just so thrilled that we have the opportunity to be supporting and hearing from Ijeoma today. And just to tell you a little bit more about her research, her specific research that she'll be talking about today focuses on applying epidemiologic and implementation science methods to evaluate health disparities, inform public health policy, deliver tailored health interventions. So at this seminar, she's going to share her research on using longitudinal population health data to investigate the burden and risk of multimorbidity in people with a particular condition, asthma, to inform targeted population health interventions. Although her focus is on asthma, the work that she is going to present and the work that she's doing is highly relevant to the work that the network promotes around chronic disease surveillance, chronic and studying chronic disease and diabetes within healthcare populations. So, and just as a second, I forgot to mention, we're really pleased that Ijeoma's faculty advisor is also here today, Dr. Karen Tu, who, as Dr. Fazli did, will be leading the question and answer period at the end of Ijeoma's talk. So without further ado, please join me in welcoming Ijeoma. Go ahead.
Thank you so much, Lorraine, for the kind introduction and for inviting me here today. Please let me know if you can hear me clearly and if you can see my slides. Okay, all right, thanks. So I'll be talking about my research on using advanced data science methods to examine the trends and predict the risk of multimorbidity in individuals with asthma. I'll start by saying that I have no conflicts of interest to declare regarding this presentation. There is a recent push to shift from single disease-centered healthcare and public health approaches to multiple disease-centered approaches for better health outcomes. This brings me to the concept of multimorbidity, which simply put means having multiple chronic health conditions. My presentation will focus on multimorbidity in asthma as a use case. There is no standard definition of multimorbidity, but the most commonly used definition is the co-occurrence of two or more chronic conditions in one person. This is also the WHO's definition of multimorbidity. The prevalence of multimorbidity varies across countries and settings, depending on the data available, the measure that is used for multimorbidity measurements, and the conditions included. But generally, most community-based studies in both high and low and middle-income countries have reported a prevalence ranging between 15% and 43%. One important message from these studies is that the prevalence of multimorbidity is rising globally. It has also been found that multimorbidity is happening more at younger ages, and it is a big challenge to population health and health systems. In Canada, about a third of the population has multimorbidity, and the prevalence has increased over time, especially among younger adults. A population-wide study showed an increase in the population prevalence of multimorbidity from about a quarter in 2003 to a third within 13 years. That's between 2003 and 2016. Having multimorbidity means having more complex health plans and a higher pill burden. Multimorbidity is also associated with poorer health outcomes and excess deaths, especially deaths that are premature. All these put together place a huge burden on the individuals affected, their caregivers, and the health system. A brief background on asthma. Asthma is a heterogeneous disease characterized by chronic airway inflammation. Asthma burden is high globally, and with global warming and climate change, the prevalence of asthma is expected to continue to increase. In Canada, asthma is the third most common chronic disease with the highest burden in young adults. So one may ask, why should we be interested in multimorbidity and asthma? Asthma usually starts at a young age, so people with asthma may be at a higher risk of developing other health conditions. Cross-sectional studies have shown a higher prevalence of other chronic conditions in people with asthma compared to those without asthma. Some immunological mechanisms have been proposed to explain these associations, and multimorbidity in asthma has been associated with a high economic burden. This study is necessary because most studies on multimorbidity have focused on older adults, but we are seeing now that multimorbidity is occurring at younger ages. There is a lack of longitudinal studies of multimorbidity in people with asthma. The few studies on multimorbidity in people with asthma have focused on allergic or respiratory diseases, but people with asthma could also have other chronic conditions such as diabetes and cardiovascular diseases. Also, there is a need to include diverse sources of data in prediction models for more accurate predictions of multimorbidity. And so the availability of population-based longitudinal data and advanced data science and machine learning methods provide the opportunity to fill these research gaps. The goal of this study is to determine the burden of multimorbidity and predict its risk in people with asthma. The objectives are, 1, to describe the prevalence and pattern of multimorbidity over a 10-year period, 2013 to 2022, among adults with asthma in Ontario. Second, to develop and internally validate machine learning prediction model for the 5-year risk of multimorbidity among adults with asthma in Ontario. To achieve these objectives, I'll be using different data sources linked at ICS. These include clinical data such as physician diagnosis, laboratory and medication prescriptions, health services data such as hospitalization and emergency department visits, social data such as demographics, socioeconomic and immigration status data, and environmental data, which include air pollution and active living environments. For this study, the following 18 chronic conditions listed on this slide will be used to define multimorbidity. These health conditions have been shown to constitute a high burden to the health system in Ontario, have been used in previous multimorbidity studies, and have validated algorithms for identifying them from health administrative data. To achieve the first objective, I will conduct yearly repeated cross-sectional studies. The participants will be Ontario residents, 18 years or older, living with asthma during the study period. These individuals will be identified using validated algorithm at ICS. I will define multimorbidity as having any two of the 18 chronic conditions that I showed in the previous slide. I will describe the prevalence and 95% confidence interval of multimorbidity for each year. I will also describe the prevalence by subgroups of social determinants of health, such as age, sex, immigration status, neighborhood income, and neighborhood marginalization indices. The prevalence of each chronic condition will also be described by year and sex. Then I will perform sensitivity analysis by using 3 or more chronic conditions to define multimorbidity. This is to enable me capture a higher degree of multimorbidity and see how these might affect our interpretations. For the second objective, I'll be using a population-based retrospective cohort study design. The participants will be Ontario residents 18 years or older who are newly diagnosed with asthma between 2013 and 2017, and who do not have the diagnosis of any of the 18 chronic conditions of interest. I will develop, internally validate, and compare the evaluation metrics of 5 machine learning models. The predictors, which we refer to as features in machine learning, will include demographics, socio-economic, laboratory, medication prescriptions, and environmental data. The outcome, referred to as label in machine learning, will be multimorbidity using the same definition that I used for the first objective, which is 2 or more chronic conditions out of the 18 in one person. I would use the first 2 years, the 2 years preceding asthma diagnosis, to gather data on the predictors, and then use the period of 5 years after asthma diagnosis as the window to predict the outcome. This is my machine learning pipeline. Raw data from ICS, which includes the clinical, health services, social and environmental data, will be pre-processed first. So this phase of pre-processing involves data cleaning, splitting the data into train and test sets in a ratio of 80:20, and handling of missing values. Next will be feature engineering, which involves creating, transforming, or selecting relevant features to improve the performance of the machine learning models. This phase will include encoding categorical variables into numerical forms, scaling of numerical variables, and selection of relevant features, which will be informed by domain expertise. The models will then be trained on the train sets using stratified 5-fold cross-validation. This means that for each time the model is trained, the training data will be split into 5 parts. 4 parts will be used for training, while the 5th part will be used for testing. This will be repeated 5 times. And then the outputs of the model will then be summarized before using the model to make predictions on the test set of the data. The models will be evaluated on the test sets, and the evaluation will be done for both discrimination and calibration. For discrimination, I'll be using area under the receiver operating curve, F1 score, and precision recall curves. For calibration, I'll use calibration plots. Separate models will be developed for sex and marginalization indices to assess the models for bias and fairness. Sensitivity analysis will involve repeating all the machine learning analysis using 3 or more chronic conditions to define multimorbidity. This study is significant because it will be the first to predict the risk of multimorbidity with machine learning using a broad range of social, clinical, and environmental factors. It is also the first population-level machine learning prediction model for people with asthma. It will help to identify and accurately predict population segments with a higher risk of multimorbidity, who can be targeted by policymakers, public health practitioners, and clinicians for preventive interventions. The study has the potential to inform equitable public health interventions and equitable population health interventions, and public health system planning in Canada. And ultimately, we want people with asthma to have an improved quality of life. These are some of the references that I've selected for this presentation. And I would like to acknowledge members of my thesis committee and co-authors, Dr. Laura Rosella and Dr. Karen Tu, who are my co-supervisors, Dr. Andrea Gershon, who is also on my committee, and Dr. Zara Shakeri. I would also like to acknowledge members of my PhD epidemiology cohort and population health analytics lab, who have also contributed to this work. I would like to acknowledge that this work was supported by Vanier Canada graduate scholarship to me, which I received from Canadian Institutes of Health Research. I'll also acknowledge University of Toronto Connaught Doctoral Award, the Novo Nordisk Network for Healthy Populations Graduate Award, the Data Sciences Institute Data Access Grant, and the CIHR Project Grant for Population Health Analytics. Thank you so much for listening. I'll be happy to answer any questions.
Thank you, Gioma. That was a beautifully presented presentation or talk, and really exciting work. I'm going to pass it on to Dr. Tu to lead question period.
Thank you. So, sorry, does anybody have any questions that they'd like to clarify with Gioma? I'll just say she's had to rejig. Originally, this was going to be an EMR data. So, and she's had to rejig. And I'm just, have you been able to get all the cohorts and access to the data, Ijoma?
Yeah, so I have all the ICS approvals done now and should be having access to the data in the next few weeks.
Okay.
Yeah.
And are you building your multimorbidity measures? Are you going to specifically get the different disease cohorts, because we don't have all of them, or are you using an existing multimorbidity measure that you've seen in the literature?
So for the multimorbidity measurements, I'll be using the 18 conditions, the 18 conditions that I shared on the slide. Now, these 18 conditions have validated, they either have ICS-derived cohorts, which have already been derived in ICS, or they have validated algorithms that are used to identify each of those chronic conditions. And then for my specific study, I'll be defining multimorbidity as having 2 or more of any of those 18 conditions.
Do you have any other questions, Karen, or?
No, I'm okay.
Okay, so Ijeoma, I had a question actually. This was really interesting. So I actually had a couple of questions. One was related to just I'm not as well versed in AI and kind of the utility of the tool that will be derived. I understand that it's like it can be a tool that people can apply to their population to, to predict future risk of comorbidity in people newly diagnosed with asthma, either at the point of clinical care or in more population planning. However, is there a plan as well to actually do the old-fashioned identifying chief or independent predictors of comorbidity in a population of newly diagnosed patients with asthma? Just less to be less because it will be less useful as a tool, but more useful perhaps to understand, to advance knowledge around what are the most important predictors.
Yeah, that's an excellent question. So I think I see two parts. I hope I understood you correctly. You're asking about the utility of the models and whether there's also plan to use the traditional methods to identify the individual predictors. Okay, so in terms of the utility of the prediction models, there's a recent shift also from using prediction models for clinical decision making only to actually use them for population health planning, right? And intervention at the population level, knowing fully well that that is where we can reach a larger group of people, and we can actually demonstrate more impact if we intervene at the population level. So that's what we are hoping that this tool could be used for. Unfortunately, in the timeline of my PhD, we will not be able to deploy the tool, but that's further work that can be done along the line. And then for the second part of the question, which is the individual predictors. So what the machine learning model would do is to help us identify so it's in addition to predicting the risk, we can actually identify which predictors are driving the predictions, right? So that's something that we're able to use, and that has also informed the choice of the machine learning models that I want to employ in this study, because I want to employ those that can be interpretable, those that we can explain, those that can let us know what's going on. So even though we see machine learning models as a black box, some of them can actually be interpreted in a way that we can know what is driving the predictions. So that's something that we plan to determine. That's something that I plan to determine when I run the models. I don't know if that answers your question.
Very much. Thank you, Agioma. That was very helpful. Does anyone else have questions for Agioma? Just looking, any hands up? So while people are thinking, I'm going to see, maybe I can ask my second question. I know that you've got your standard definition of at least 2 of any of those comorbidities, and then with a sensitivity analysis of at least 3. But are you planning on also looking at, specific comorbidities? Like, is there an interest in understanding, tools to predict maybe ones that are like, there is a difference between, for example, hypertension and diabetes in terms of burden, as an example. So is there any thought to sort of teasing out some of the ones that are in that list of 18?
That's an excellent question. It's something I've really been thinking about, because I know that there's this debate that using simple counts of chronic conditions is not, it may not be intuitive enough, but then there's also been arguments, and different studies have shown actually an overview of systematic reviews comparing the simple counts and weighted indices like the Charlson Comorbidity Index and the ACGs. I have shown that actually there's no consensus on which one is better. And what is being proposed is that it depends, the choice should depend on the aims of the study. So with bearing that in mind, and the fact that we might say that a simple count of chronic conditions is too simplistic, but then if we think from the patient's perspective, having more than one chronic condition is already a burden on the patient in terms of maybe accessing healthcare services for the different conditions and taking different medications. So that's why I think that starting with a simple count, it's something that can be useful, because even comparing studies, different studies in different contexts is also challenging, because the list of conditions is not the same in the different settings. But that is as it may, I've also thought about looking at conditions that could, one, have a cluster of risk factors, right? Conditions that have similar risk factors. That's something that I'm also thinking about exploring. So also looking at conditions that could even be related to medications, asthma medications. I intend to explore that. And in terms of burden, I know you talked about hypertension and diabetes, for example, but then I've also been looking at the literature to see what mechanisms could actually, show or explain why some certain chronic conditions may occur in people with asthma. And just like I mentioned earlier in the presentation, like immunological mechanisms have been proposed to explain the link between asthma and psychiatric conditions and even cardiovascular diseases. Then there's a bidirectional relationship between asthma and diabetes. So if we're even looking at diabetes and asthma, we could even begin to think epidemiologically about reverse causation and all of that. So it's a complex, problem to study, but the more that I get into it, the more that I'm thinking about ways that we can come up with something that is feasible to achieve within the timeline of my program. And there's, of course, more room for further research. Yeah.
No, that's great. And I'm certainly not suggesting that you incorporate these into your thesis. You've got enough to do. But I would say that you've definitely got a number of ideas to support the next 5 years of, after you finish your thesis, another 5 years of exploration and a research program. So yeah, no, that's terrific. There's a question in the chat. And I'll read it out. So, will you take into account age of onset of asthma in your analysis? And also wondering if it's possible to consider how your results might affect those with asthma and may differ to those without asthma.
Thank you so much for that question. This is actually related to one of the objectives that I have not included in this presentation. So the other objective of my thesis is comparing the risk of multimorbidity in people with asthma and those without asthma. And so for that objective, I'll be including the age of onset, also in the comparison. So that's a causal inference objective, which I did not include in this presentation to make it simple. But yes, in a nutshell, yes, age of onset of asthma is included. That data is collected and it will be included in the prediction models as well. And then the second part about individuals without asthma, I'll be answering with the other objective that I didn't present today.
Great, thank you. So that takes us to just about the end of our seminar today. I'd like to once again ask everyone to join me in thanking our two excellent presenters, Ibrahim Ghanem and Ijeoma Itanyi. Really, really wonderful work. And it's just so wonderful to see, all the opportunities, cutting edge methods and opportunities that emerging data sets and emerging methodologies are affording our young graduate students, because it's just going to really push the field so much further, and this, your work, is both of you, is going to contribute a great deal to our understanding of predictors of disease and outcomes. So that completes the end of our seminar today. I want to thank everyone for joining, and in particular for our faculty advisors for leading the question periods. Please ensure you complete today's evaluation for the session. Lydia's added a link into the chat pod, but it will also be sent via email. And our next Network for Healthy Populations seminar will be on Tuesday, February 18th, 2025. It's not on the Monday because that's Family Day. And actually for that seminar, I will be presenting some work that I have launched for a diabetes prevention program called the ADAPT-M program in women who've had gestational diabetes. And we're launching that program in with partnership with Trillium Health Partners and CarePoint Health. So we look forward to you all coming to, I'd love for your feedback on the work that we're doing. And please go to our website for more information and to register for the event. Thank you all for coming, and thank you for sticking right to the very end. And once again, a big thank you to our speakers. Take care, everybody. Stay warm.